Are we ready? Okay, everybody been to a P? Okay, are we recording? Well, thank you very much. Right, well, good evening, ladies and gentlemen. If you're watching the recording, I'm afraid you won't be able to take part in tonight's draw for a free holiday for two in Barbados, but there we are. We're all looking forward to that later on. We're very pleased to be in the offices of IQVIA in Paddington, which are very special, I have to say. And we're very grateful to Angela McFarlane, where she is. She's in the back there. Big round of applause for Angela. Thank you very much. Providing our venue and the three-course dinner for us all later this evening. And because we couldn't have done it without Shane Tickell. Thank you very much for your support, Shane. We really appreciate it. So my guest tonight is the chairman of NHS England. He must have done something bad in a previous life, Richard Meddings. Richard, how are you?
I'm very well.
I'm not sure I should ask how you are, actually. So we got an hour together tonight. So I thought what we do is we'll do 45 minutes on the cricket. We'll do 10 minutes on the NHS, and then we'll do five minutes for questions. No, we don't do 10 minutes. No, okay. We're cricket people. Right. Okay, so what did you think of the cricket?
Great result, actually, and sets us up for Old Trafford. I don't really want to.
Yeah.
The big question with my sons, my daughter is less interested in cricket, actually.
Yeah.
But with my sons is whether Bairstow should be dropped or not.
Well, that's it. Should Bairstow be dropped? That's the discussion point tonight. All those in favour of Bairstow, raise your hands. Thank you. All those not in favour of Bairstow, raise your hands. Okay. All those who haven't got a clue what I'm talking about, raise your hands. Okay, fine. So, I think we can say we're undecided.
We are.
Well, you see, there's an important. It's about loyalty to people, Richard. Loyalty to people.
Very good.
Leading your team, Richard, which is your big thing. Because at the moment, you're having fun, aren't you? Because you're trying to squash 3 previous freestanding organisations into one.
Yeah, so...
what's your approach?
So actually it has been I'm pleased you've started with that, actually, because it's often underestimated just how testing and difficult that exercise has been and is proven to be. But it's essentially 5 entities, or you're quite right to focus on 3, which are NHS England, and NHS Digital, and Health Education England, or HEE. But together with NHS Improvement and NHSEs, it's 24,600 roles. And we're merging these entities, which are essentially the central head office of the 20% of the headcount. And so if you imagine running all the programs of all of these entities, and you think about the boards of these entities, so NHS Digital and HE, which have major programs underway, broad governance responsibilities, oversight, challenge, and delivering the various programs that they're all engaged upon, to keep that going at the same time as actually removing, currently we estimate 36.5% of headcount, it's a real test. And of course it throws huge challenge and anxiety into our teams who have to go through this process. And I pay them actually a huge tribute for actually the manner in which we are able to do this and the engagement with our staff. But clearly it does cause real morale issues. And unsurprisingly, so we have to work through this as fast as we can, and we are doing it. We would hope, actually certainly by late this year, to have completed on that exercise, at least so that everybody will know what their future role is. And it's very important that we do it. But if you're human for the moment, why are we doing it? And we're doing it actually because it's the other hand of essentially the mergers of the integrated care systems, and our very clear ambition or aspiration to devolve to the integrated care systems, the IHSCM. We need to devolve them. To do that effectively, it's really important to decentralise and to debureaucratise, and to remove what I would call sort of circular reporting that can happen with head offices, where the head office asks for a report, gets a report, asks some questions about it, but that reporting is not necessarily anywhere near the patient. And so actually, how do we decentralise, debureaucratise? And really the only way to do it is actually to reduce the headcount, and then also to aggregate and consolidate the various programs we have. And that will come to a topic I'm sure we'll come to later, which is how do we think at the board about prioritisation? What do we prioritise when we actually have so many objectives? NHSE has that.
Well, it's about priorities, and then people produce organisational reports that says we have 10 priorities. No, you don't. You've got muddled thinking.
So you and I have had a number of conversations, and I think we don't disagree. But if you look at the 130 objectives, about 110 of those are in primary legislation or regulation or statute. And then if you look at some of them, actually you can't step away from them. Are you not going to have objectives around obesity or early learning or autism or prostate cancer or breast cancer or ambulance response times or A&E performance? So actually you look down and say, well, what would you not want to have as an objective and then set performance measures? So the way we think about it at the board is say, these are objectives and they're therefore priorities, but what are the enabling priorities? And for me, that word enabling is a really dynamic word. And so it says, what is it that we as a board can focus on, which are, to your point, much fewer. There are fewer of these. But if we really get those right at a board level, can enable so many other things, therefore, to us be more confident in the success of so many other things. And one of those will be the long-term workforce plan. And it's clearly an enabling priority, because if we don't get the workforce right, then actually many of the other targets we have, as everyone in the room knows, remain under real pressure.
Okay. Well, let's reel some of that back, because you've covered a lot of the ground up, top level.
I'm batting like England.
What you could open it, we'll see, won't we? Yeah, when the pitch roughs up a bit. Look, Health Education England is a worry for me. Looking back on it, it's never been, I think it's probably true to say, it's never been really a very happy organisation. It's had, before you arrived, it's had some leadership crises, and it's a bit of an identity crisis. And of course, it was one of the legacies of Andrew Lansley breaking the whole thing up into arm's length organisations. Now, of course, we'll come on to you. Okay, fine. It's very nice to send you goodbye. Hold it back. Okay. And now, of course, we've got the workforce plan. We're lifting for health education. It's all very well to say we're going to double the number of places, but you've got to talk to the universities. You've got to double the number of chairs in lecture halls. You've got to double the number of tutors. You've got to double the number of supervisors back in the hospitals. And there's problems now, with the supervisors. So just talk to us. How do you see the future of health education in England as the workforce plan starts to unroll? I know you don't do it all at once, but I mean, how do you match an organisation you're trying to slim down with a demand which is obviously going to increase, that you're going to have to roll up again?
So to health education in England and its past, that's I've been in this role 15 months, so I'm not that familiar with whatever that history is. My own perspective on health education in England, and certainly the board and the executive management that manages that and oversees it actually is positive. And the manner in which and the way in which they've engaged on the long-term workforce plan and really thinking about the key enablers underpinning actually confidence in why we think we can double the number of doctors, for instance, or increase the number of nurses. I think it's 92% in the plan. Actually, I would say to you that the Health Education England team and executives have been outstanding. So I think that's the first point. The second then is you're quite right. And we have our next board meeting, which is on the 27th of July. And again, it won't be a surprise, and this isn't the first time it's come to the board, clearly. We're going to now pick up the long-term workforce plan as published. And we're going to look to see, okay, how do we get confident in its delivery? How do we get confident in how we capacitize it? And so you look at the trajectories of growth in training places, and I think it's something like by end of 2028, we'll have a 33% lift in the number of training places for doctors and a 34% lift in the number of training places for nurses, 25% for GPs. And by 2030, we look at apprenticeships, which is a new way in and a very good way in. We'll have changed the number of clinical places, clinical training places, from 7% of people who come through to 22%, and 22% of a much greater number. So you've got some real dynamics at play. Now, of course, we can't do that, and of course we can't, sitting at the head office, do it on our own. So actually the engagement with, as you say, the universities and the training colleges, and it's not just in the training places. It's okay, enough placements within the systems to train the clinicians as they come from college and actually go into places of work, health places of work. Working that through is really important. And the team is already well underway. It's not something that we've just got the plan published and now we're turning to a new chapter. In getting to the plan, actually, we have been looking already at laying the pipework, if you like, for how we capacitize it and how we bring it to fruition. But it's not an easy task. I mean, let's be very clear. It's a really major undertaking, but it isn't one you would discourage us from doing.
No,
I mean, I think it's
it
a remarkable step forward.
And it's not without controversy either, is it? Because you've got the apprenticeship schemes, which there are critics of. I'm not one of them. I think it's a very great idea. You've got shortening medical training, which already the BMA is kicking off now. I mean, just talk us through the iterations that you went through with the plan to get to that point. I mean, clearly you've had to talk to the GMC because they're not going to regulate people they don't think are well enough trained. I mean, explain the mechanics of that.
So I think, I mean, there are lots of different ways to start at that question. I won't try and go 360 degrees around the circle, but one might be, if you look at our workforce, and because for this purpose focus on the medical clinical workforce, what we do find, Roy, you and I have talked about it, is many of our trained clinicians are working nowhere near the top of their skill set. And they're working nowhere near the top of their skill set, actually, because they are doing many, many activities, which is, it doesn't need them to have been trained right to the levels of sophistication and capability that they have. So how do we think about that? We say that's right. We still need to train to the best levels. We take our brightest and our best people, and we train them through medicine. We bring them forward with some amazing people. Actually train them how we find them to the top of their skill set. So what's the answer? Well, the answer is dental technicians or physicians associates, and to bring in a greater workforce which is capable of working at those levels and allowing then those who are differently trained to operate and not necessarily operate, to provide their input and their service, essentially right to the level of training. So one of the answers is, how do we make sure that we use the workforce to its maximum capability? And one of the ways to do that is think about, well, what are the demands that our citizens have of us, and how do we meet them? The moment we have, which is the real kick-off point for me, was when I arrived in this role, and I found that we'd had 7,500 medical cases for doctors, which is 15.6% of the applications. And you think, seriously? 85% of applicants. And I expect many of those, like 85%, would be perfectly capable of being trained with superb physicians and surgeons and consultants, etc. And we only take 15% of our brightest and our best who want to come in. That can't be right. So how do we then think about lifting those volumes? It's partly lifting those volumes and training to particular skills. I will stop in a moment, but I'll then give you 3 or 4 words only, which is, and then we have to think about, okay, how is the world going to change for technology? Can we guess? Can we do better than guess? How's it going to change for technology? How will it change for skills mix? What are we going to do about the productivity challenge, which is quite a punchy productivity challenge in there? But to do that, we have a key plank within, or a key foundation of the plan is sufficient capital investment, sufficient investment in technology-enabled skills. So they are underpinnings to the plan, and they give us the confidence, I think, that we can go with ambition to grow the workforce to the levels that we think we need. Now, we may be wrong. Sorry, we will be wrong. Let's be clear, the numbers won't be the numbers that turn up. So the other key mechanism is that we are going to review it every 2 years. So it'll be kept updated every 2 years to say, okay, what's going right, what's going according to assumption, what's not.
Can I just ask, who will review that? Is that, who triggers that review?
So that's going to be a combination, essentially, of clearly NHS. So NHS England, including the HE, will have the department, no doubt, and probably, I'm sure in that review, we'll talk with Treasury. We'll talk essentially with
that's the problem, Richard, isn't it? Because if you think about Jeremy Hunt, when he was on the select committee. He was banging on about a 2-year review of a workforce plan until it enshrined in legislation. Parliament wouldn't agree to it. So now we've got it sort of on the agenda every 2 years, but one wonders really the extent to which the dead hand of the Department of Health could stop it happening. Certainly, I mean, let's just take a sort of theoretical set of circumstances. If 4 years in, the numbers didn't look right, we need to inject some more money in it. We're very much at the mercy of the Treasury, and we go around this loop again.
So, I mean, I think it's quite easy. I know you're not doing this certainly on purpose. It's quite easy to naysay and to be sceptical of the third order challenges. And the important thing, I think, is to say, is this a major step? Is it a major step forward?
Yes, it is. I agree it is. What I'm saying is, what's the guarantee when we get in?
There are no guarantees except that it's funded, it's fully funded for the first 5 years. And there's a regular mechanism of review. And the other thing.
Okay, explain the mechanism for us, because that's what I couldn't get out of the documents that I've read. I don't understand how that review is triggered, because it is quite important. Because if it can be easily swept aside, we're no further forward.
I don't think it needs to be swept aside. I mean, there's a clear commitment to review that every 2 years and to review the key assumptions. And I'm sure it will be the same broad groups or constituents in review that. When we did the plan, actually we consulted both very widely and also quite deeply with certain of the think tanks, for instance. And we tested the assumptions with them and they reviewed the assumptions for us. It's interesting, the NAO is about to do a review, but purely on the model. So the NAO is about to do a review and has the model being
the Health Foundation, I think.
Health Foundation, but we also did talk with Kingsford and Nuffield Trust and a number of colleges.
Yeah. So that tested the assumptions. I'm just interested in what triggers the review, because I think that's really quite important.
So it's a calendar.
Seems to
it's
be
a calendar trigger. The important thing is it's a calendar trigger. And I was going on to say that from my own perspective, the important thing is to have launched what I think is a seminal piece of work of the way the NHS should think about long-term constituencies. And changes in technology, changes in skills community. These are really, really important factors. And I think that's the important point. What does the UK think of the NHS? And they think we're underperforming. We know that. We know that confidence in our performance has dropped significantly. Certainly over the last year or so, it's dropped really steeply. But what has not fallen away actually is the population support for the NHS and what it actually stands for and its underlying principles. So you put out a process where here is a workforce plan. You put it into the small p political world, the big P political world, have a commitment to do it every 2 years. I think that's probably got real legs to it. Who's going to stand up and say, you know what, we're not going to do that?
Well, it'll be a brave government, and I suppose it will depend on the economy. Let's think a bit more about the workforce plan. It's the first one we've done in 20 years. The last one was in 2003. I imagine everybody's forgotten how to do one of those. How did you start with it? Where did you go with it? Because it's a hugely complex topic, isn't it? I'm kind of interested in how you got shaped. So it starts with a whiteboard and a magic marker.
Yeah, I mean, it starts with a small team essentially at the centre, capturing what is it we think we need, what do we think the vacancies are, what do we think growth rates are, all the things you would expect to build into an econometric model, which is effectively what it is translated into workforce.
So is that doctors per 1,000 population?
Yeah, potentially, and also the skills mix point I made earlier, which is actually imagine actually we can change skills mix. What does that actually do to the level of service provided? And then there's a drill down below that into, let's go into particular, again, constituencies of health service. So what do you think is happening in primary care? What's happening in secondary and acute? Where are the vacancies?
And in the report, in case you haven't read, there are 53 subdivisions.
Yeah, absolutely.
Yeah, and that's, I mean, there's a huge amount of work. I'm just sort of coming from the manager's point of view, I'm just interested really, how do you start that enormous piece of work? Because if you can't define the workforce until you can define work, and you can't define work until you understand how work will be influenced by the things that we're seeing the technologists and
So,
data and all
which
the
is
rest of
why,
it.
I sort of said right at the start, I'm not going to walk, I won't walk behind all the 360 degrees of the circumference to say how do we look at it, but effectively you did that.
Yeah.
So effectively you take a look at all the angles and you say, is that still consistent with that assumption? What does technology do? Are we shifting to primary? Are we shifting to primary? And we made some assumptions. I know you were thoughtful, I think, in one of your pieces about the assumptions around social care, where we simply made the assumption that actually social care will continue to provide broadly the same level of support that we currently have. But that's a boundary issue for the NHS because they lie outside our control, but they aren't within the NHS.
Well, I thought it was very revealing, just to go off on a tangent, it was very revealing to listen to Hancock talking to the COVID inquiry, where he said we've got NHS and social care over the door, but I had no line of sight. Didn't even know how many care homes we've got, which that's.
So I think there are 19,000 providers.
Everybody scurried around and found out what the numbers were. But I mean, it's very important that because it does kind of tell us where the strains are in the relationship.
Yeah, can I just reflect again on that your question, very valid question about confidence about the 2-year review, which actually I would say to you that we have had, not just support from the department and Jeremy Hunt in his guise as Chancellor, who have come with me on the Health Select Committee for many years, and Health Minister, but also from the Prime Minister. So this plan has had huge support and interrogation from, but huge support from the Prime Minister. And then if you look at the opposition, the main opposition, again, it's very interesting to hear, particularly on the topic of workforce. I mean, I think that the realism or the realization that actually workforce is the deafening challenge to many of the other issues that the NHS faces without the workforce. So I do think across the political spectrum, you see very real support.
Well, I was going to ask you that because I mean, you kind of almost robbed me of that question because in a sense, you've been pretty clever here, haven't you? You said this is the NHS workforce.
Yeah, it is.
Politicians, do you want to support this? And it will be quite difficult, I think, if there is a change of government, an incoming government, to say no, we want another workforce plan because what you've done is independently.
Well, we produced the workforce plan, which the then Secretary of State of Health asked us to produce. I mean, not the plan, but he asked us to commission a workforce plan. And so we followed through and we produced the workforce plan that the NHS thinks we need.
Do you know what Labour think of the workforce plan?
I think it's supportive.
I mean, because they kind of ducked the question.
Well, I mean, I don't want to get into politics at all, but I do think that if I was watching the news, I think they said that the plan copied their plan. So that suggests that they're not.
That was disgraceful, actually. Why you copied their plan? Made your own up. Yeah. Okay. Let's talk a bit about technology. The NHS has made a mess of technology for most of the time I've been around it. I would say that before I get thrown out of here, but I mean, if you look at the simple things, we can't seem to get the basics right. We've still got nurses wandering around wards doing blood pressure and temperatures and all the rest of the observations. And they're still writing it down on a piece of paper when it could be Bluetooth into the back end of the electronic patient record. I mean, how have you viewed technology and its impact in the workforce? Because I just want to say this. It's all very well talking about productivity. I don't talk about productivity anymore because I was threatened with GBH when I talked to a nurse who'd just come off a night shift. And I wanted to talk to her about her productivity. I thought she would stab me. But if you talk to how can we make your work easier, then productivity immediately starts to happen. So where have you gone to for the sort of the Mystic Meg bit on technology?
So the first thing to say is if you look at many other industries and you look at the pace of transformation, technology writ large, digitization.
Look at AI the last 3 months.
Look at AI and ChatGPT and all the rest of it. Look how potentially dramatic it might be. So it clearly is a really important factor to think very, very hard on that. But what often gets missed in technology is it's quite straightforward, oddly, to produce the front end of the app or the front end offer that the patient sees. The difficulty is how do you change all the processes, the patterns, the workflow processes, the engagement amongst the staff, the way decisions are made within acute hospitals or between primary and secondary. And that's the hard work. So there's, for instance, something called ambient documentation as an example. And ambient documentation essentially is, exists in many industries where people will simply talk into a microphone. The microphone picks up their words, chooses keywords because it continues to learn, and actually produces a summary diagnosis or summary view of the patient. We pretend it's a doctor doing this. And as it machine learns, it gets better and better at keywords. And then the doctor gets a chance to review it and actually can then send an issue as instruction, okay, go. So you can do that in many industries, and people can talk into their machines and they get better and better reports and they get much more tightly focused on the things that really matter, you get a really good diagnosis. The question then is, when you say go, what happens to that report? And of course, it's where does it go in terms of instructing referral letters? Or which systems, data system, does it upload? Is it the patient system or is it the hospital system? It should be the patient system, but it would tend to upload to the hospital system because the hospital is interested in unit processes. So thinking how you change the workflow to enable something that clearly exists is where the challenge lies. So I realise I'm taking on some where we gone. We're doing some very major things. And I think the important thing is to understand what the centre owns as opposed to what is delegated, so disaggregated out through the systems. And what the centre owns are certain spinal systems. They'll own a taxonomy, definitional taxonomy. That's really important. We should own a target architecture, which helps us decide what is it we offer into primary, into secondary, into tertiary, and then we can start to map to who the suppliers are. What are the engineering principles that we own centrally so that you have hygiene levels? So if a supplier wants to come in and offer their services, maybe the most brilliant app, they want to offer their services for the health service, they have to be able to demonstrate connectivity through to something, through to the electronic patient record of primary. So we at the centre need to own target architecture, engineering principles, and certain spinal systems that are essentially the platforms that go everywhere. One example, federated data platform, without doing that now, out for procurement, that has the ability essentially to interconnect the data we have through all the acute systems into primary without anyone having to change their data. In other words, the federated data platform will pick up the data from all of the trusts without them having to write them into a different machine code language and allow us actually to get that connectivity.
It's called normalization.
Could be.
Normalization of data. Yeah.
You've got the NHS app, 32 million subscribers. It's most amazing.
Well, Labour are going to run the whole NHS.
I think the app has an ability to be, truly revolutionary. We have to remember that some people will not want to use it or will not feel they are capable of using it. But actually, the high volume will.
The answer is it creates the time and space that look after people who won't.
Correct.
So let's look at the other end of technology. Now, what can technology tell us about, or what are you expecting technology to tell you about demand for the future? You just touched on some issues about that were really issues of public health. And there is, I think, an argument now about the relationship between public health as a forecasting organisation and the NHS as a delivery organisation. You know, the NHS is the dust cart that clears up after the ordinary show of life. But there's a separate piece in public health, I think anyway, that we don't think about population wellness. We think about population health, and that's a whole different thing. How do you see the role of the technologists and the data managers to help you forecast demand? And do you think it's reliable?
So I think all forecasts are best indications that you travel towards, and then you adjust if you see they're correct or they're not correct. But what do I think? I think the key for me there actually would be capturing properly patient data in the electronic patient record, and then using that, capturing whether it's in the NHS numbers, a single data aggregation point, real information about our citizens and our patients. So what do I know about patients? And if you imagine, which I get very scared about in public they say. When I'm standing in the kitchen talking to my wife and I say, you know what, I think I might get some new slippers. Sorry, I use these slippers. And then suddenly my phone lights up with all sorts of adverts for slippers and other sort of things I think are associated, just listening in. I don't think we'll go there, but actually what's really interesting is just the ability with technology that's definitely through today to really understand patients. So imagine that we can capture the information about our citizens, but to do it in a way that protects the data privacy of our citizens. We'll be very careful about information governance, so we have to anonymize what we can. But actually, imagine a world where actually we really can capture real patient data and think how it would be. So whole genome sequencing, and they're remarkable. And we do that today.
There's two bits.
No, so whole genome sequencing. So you capture that, you have a DNA printer that a young, in this case, babies newborn or newborn with tend to be serious afflictions. We have their DNA print. That is utterly remarkable and allows us to intervene and look after
that. I agree with that. I mean, there's irrefutable evidence then that this person is likely to get this, be that, what have you. I get all that. But the difficulty that public health has, I think, is that largely public health is stopping people doing what they want to do or what they have done or what they are doing. I think I'm right in saying, no doubt people will write to me and tell me I've got the wrong figures, but I think I'm right in saying that 53% of people who present in primary care present with something in some way lifestyle related illness.
No,
and so all public health can do is to say, stop smoking, stop this, don't do that. That's why most public health messages fail, I think, because if you look at the public health messages that have worked, seatbelts in cars, crash helmets on motorbikes, health and safety legislation, and stopping smoking in the workplace, which is the defining piece, I think, of my argument. And I wonder, how do we get, I mean, it's the power of legislation. I mean, we did it with the sugar levy, not a tax, it's a levy. But the government have backed off doing that with food because they say that poor people can eat crap food. That's really their argument. So where do you see this sort of philosophical argument around public health and its success?
Sorry, I misunderstood you. I completely agree with the point you're making. I mean, I think that, and the way we might be able to contribute to that is by shifting our own offering more into primary and more into community, getting closer to the patient. But you're quite right. If you look at, I mean, I often use this phrase, which is, what's the sort of our central challenge that the NHS faces? And I say it's exponential growth in demand into an undercapacitized system. And the exponential growth in demand, where demand is actually surging. One of the reasons it's surging is obesity, which is you're partly more than hinting at, but lots of other causes of health challenges. And what does obesity do? Obesity triggers 13 cancers, diabetes 2, cardiovascular, musculoskeletal issues, 28%, I think it is, square bracket that number, about 28% of our population is obese. I think in Europe, we're the second most obese nation in Europe. And you look at that and say, well, what on earth is going on? And so we will do our best to engage with it. And you have then in primary care social prescribing, lots of different ways to go at it. We've got there's the new, I was going to use the brand name, but we have a couple of new drugs that have been approved, which are appetite suppressant, which are meant to assist. There's lots of ways to try and go at it.
It's never just given on out.
No, but you are right that these issues are much more deeply embedded in the way our society.
I think we need a whole new approach to public health. That's a discussion for another day. It's one of my favourite topics, but we'll do it another day. Okay, let's talk about something much easier. Let's talk about capital in the NHS and the 30 new hospitals and the 5 that are falling down. What's the latest?
So, if you want to go to the new hospitals programme, again, actually, there's another topic.
Complete waste of time. Yeah.
I think we have, which is very good. And actually, one of the ministers, Nick Mark and Lord Markham, actually led for the Department of Health, and they have now agreed with Treasury 22 billion funding for a new hospitals programme. I think that's an important, it is a really important step to have that. There's some very sensible obligations upon us in terms of the method of delivery, modern method of construction and modular building.
It's
and
interesting, we're going back to the Labour modularised building system, yes, where they were built at places like Friendly Park and King's Lynn, were built using a product called Durox blocks, aerated concrete.
Oh, that's right.
which required very slim foundations, and the roofs have all gone rotten and they're all falling down. But in fairness, they had something like a 30 or 40-year life, and because we didn't refurbish them or what have you. But I mean, it does seem to me a modular approach. Let's face it, these days you can have a hospital delivered with 20 or 30 lorries and porter everything and bolt it all together. You don't have to go through this palaver of.
So I think there's a mix, isn't there? I mean, I think you're doing that. I think you're saying about that partly for the effect, which you're quite right. But actually, why do I need bespoke design of the looms I'm going to put into a hospital? They're all different. Why would that be? Because we can use our bulk purchasing, etc., commercial power to be much more efficient. And there are many similarities in hospitals, and then there will be, as you use, some differences in terms of the delivery and what is actually quite complex.
That's the power of the consultant for you.
On capital, I was going to say, I mean, I don't want to be difficult, but I think if you look at the last decade or so, we are 55% capital lower spend than the top 14 countries in the EU. It's part of this piece of work that's done, I think, by the Health Foundation, which actually showed that over that last decade, I think the health service has received investment 21% lower than the average for the major 14 EU countries. And that is a significant one. Where you really see it is in capital. And again, I look at it from a commercial private sector basis, and the fact that I think I'll probably get slightly wrong, our capital budget last year was 7.9 billion, but our backlog maintenance alone was 10, actually tells you that much of the issue, and it goes to where productivity is challenged quite often, it's actually what's the quality of the estate. And in capital, it's not just the estate, it's not the buildings alone, it's the kit, the equipment. And so again, when you look at it, when I arrived into this role, one of the things that really surprised me is that I think the average number of scanners per million people in the OECD is 19 per million. In NHS England, it's 8. So we have less than half the average scanners, MRI, CT scanners, than you see in the OECD. So when you think about capital, it's not just capital in terms of shining new hospitals, or actually where the government's committing really powerfully. And we are seeing real monies come through on CDC's community diagnostic centres and surgical hubs. And there is this 22 billion now committed to the new hospitals programme, but I think we've got quite a lot of catch up to do. And also goes across to equipment.
And might I say radiographers, because we don't have enough of them either.
That goes back to workforce. Yeah.
Well, and all roads lead back really to the workforce. Talking of the workforce, I mean, I can't not mention the strikes and our colleagues, the junior doctors. What do you think? I mean, I know you're going to tell me.
I'm going to tell you that.
Let me give my answer is I'm leaving it to the unions and the department.
We're leaving it to this isn't.
This is not a matter for me.
It's not for NHS England. It's a matter for government and the unions.
But how are you going to? What's happening in the department? Because we got the juniors going on. Junior doctors, really, is a stupid name. We got junior doctors going on strike next week. How are you managing that?
So our clear obligation and clear focus is to try and make up for and find ways to protect our patients and our citizens as far as we are able against what will be a very disruptive, it looks like a very disruptive period running. It's a 5-day strike by the juniors, and then a day afterwards, so we have the consultants go out for 2 days. So there's only effectively 1 or 1.5 days of, I've got a clear operation in that period. This is the longest, I think I'm right, you'll probably know more than me, it's the longest period of industrial action that the NHS has had to deal with. But I'm not ducking the question because I'm ducking a question. I'm ducking because it's not in my responsibility.
No, I'm just interested in how you're managing that. I mean, I get every day we've been on strike thus far. We've lost 100,000 places on the waiting list. So that's knackering the Prime Minister's target, I suppose. I mean, now we must be, I know somebody will correct me, but we must be around 700,000 people, or we will be, who have been knocked off the waiting list. And that's a hell of a lot to make up in the trust, isn't it?
I think it was a touch over 600,000. I think was the extent of rescheduling of electives.
And the thing about it is, I mean, when the unions say, oh well, if hospitals are safe because we're going to manage the blue lights and all the rest of it, fine. But what they forget is people whose clinical need have moved them to the front of the queue on the waiting lists are being knocked off the waiting list, and it is dangerous for them to have to wait.
So I mean, the government. This is the government and you. I mean, the government is. I know that they clearly get that. They clearly are very concerned about that. It takes two to negotiate. I mean, this isn't, I think, something that the government wants to see. So I don't think they're not being at all relaxed about it. I think they would, no doubt, behave consistent with where we are, which we don't want to see this. But again, it's a matter for government and unions to agree. And looks like a very difficult argument. On the electives, can I just give a couple of facts? I'm sure people in the room know it. Actually, what's really interesting about the electives, I think, is that it's a big number. 7.4 million people are currently
they don't all in operation.
Well, 3% actually require surgery, which requires an overnight stay, and it's something like 16 or 17%, including the 3, require surgery. So actually, over 4 in 5 of the elective backlog actually is essentially an outpatient sort of. I'm not saying it's not.
No. That was all in Jim Mackey's 3 to 5 year recovery plan, which is, I think, still a realisable plan. You're still working to that plan.
We definitely are, and I think on the backlog, I mean, I would pay a huge tribute actually to the NHS, and particularly its work. So if you think what emerged out of COVID and the pandemic, and in one stage, I think, didn't the Secretary of State say we thought we were going to get a waiting list of 30 million? But actually, if you look at what's happened, the 2-year waits, and 2 years is a remarkable period to have to wait. So I'm not.
That's really come down.
It's gone. Yeah. So the 2-year waits have gone.
It just shows you what can be done. I've just got an eye on the time.
Oh, sorry.
So forgive me cutting across your.
Can I just say we are still very focused on delivering the 65-week waits number target by end of March next year. We're still very focused on delivering that, and on the 78-week waiters, which is a year and a half. 78 weeks slightly hides the fact it's a very long period to wait. A year and a half, 90% of that waiting list has been reduced already, in spite of the industrial action that we've been dealing with.
Let's go back to primary care. Let's think about the future of primary care. When you did the workforce plan, did you envisage changes to primary care? I mean, Wes Streeting is talking about, well, he had a bit of a bun, I'm not sure what he was talking about, but he was rowing about the future of the GP contract. If we go up to Wolverhampton, you can see the GP.
My hometown.
Yeah, Wolverhampton Wanderers. Wolverhampton.
I could take it more, mate.
Oh, he's gone very posh. John is just saying he's from Wolverhampton. Everybody's from Wolverhampton today. If you go up there, you can see the success they've had with the trust taking over the GP practices.
Some GP practices, yeah.
Well, yeah, 717, I think they're taking over. Other places, they've got GPs that rather die than lose their independent status. I mean, where do you see that going?
I mean, I think it's a really great question, because if you look at the agenda for the board, and what are some of the key components of that agenda for primary care is right up there. And what is it we can do with primary care when it's a service under huge pressure? And I think they are GPs, and not just GPs. It's not just GPs. It's the multi-skilled workers who work in primary care do a remarkable job. I mean, there is a stat which, so I don't get across, because I do know there's a real challenge with access, and people can't always get access. But what's the population of England? 57. of England.
Oh, England, sorry.
Of England, it's 57 million. And how many GP or primary care appointments are we doing every day? 1.1 billion. The population is 57. Sorry, in every weekday, let's be clear. So even so, that's 5.5 billion appointments. That's 10% of the population every week. Now, it isn't 10% because there's repeat. That said, it cannot be.
We get 93% of first contacts for 11% of the budget.
Very good point.
So how do you?
So going on to it. So I think we have to transform. I think we have to transform the 6,600 practices. I don't think one reforms through compulsion. Again, remember these are all private sector, small independent businesses. Occasionally, they're aggregations of practices. Again, private sector owned. There is no compulsion, but there is essentially offers. So what are the different ways of working that we might imagine to offer to primary care, essentially to enable them to work in a way they find much more satisfactory and fulfilling? And there are ways to do it. There are ways to say, okay, you guys, you look after your patients at the front, and we will take off you all the admin burden, and we'll provide centres, so you haven't got to man a phone, which, by the way, isn't cloud telephony first thing in the morning to get the queuing. We'll get e-consultation available to you to help you to triage how your patients come at you. And we can do a lot of that background administration, plus the burden of reporting to NHS England, to region, to PCN, to ICB. All that reporting, we can think about how we streamline it and take a lot of the pressure. And that would change their world.
The back office and middle office offering. I mean, we tried that with the Darcy centres, and it kind of didn't work because it was handled politically badly. But there is certainly seems to me to be a kind of an intermediate place now between what primary care offer, what hospitals offer, and there's a great confusion in that crossover bit in the middle. And redefining that bit in the middle, I think, would be quite helpful to a lot of people. I just want to touch quickly on apps. You talked about the NHS app, but I mean, a lot of people now got their own health apps and so on. I mean, I'll just tell you, one of our sponsors tonight is Orca. They're very clever. They're providing a kind of certification and a validation for apps. Do you see? I mean, where do you see that going?
Well, this is a personal view and ambition. And I should quickly then add, if you haven't worked out already, I'm not a technologist, but I actually do think that within the NHS app, the ability to offer multi-functionalities and other reasons to go to that, actually to find out information. That information might, your other question, contribute to health outcomes. But what is it we can put and make more available, and then actually have more and more people come to the NHS app as if they might go to Google.
Yeah.
You know, so can they come to it and get much more footfall? And they aren't just doing it to do repeat prescriptions, make appointments, but because actually there's lots of other information, guidance to that. And that will, Roy, it is, I think it's 2 or 3 years where we think about our wearable Fitbits and gadgets and the connectivity. And I can tell you my heart rate now is probably slightly higher than normal as I sit here. You know, and we get this connectivity. The world is going to change. It's going to change in a revolutionary way.
I think we've only got to look at AI and see how that's changed. I'm conscious of the time. Right, has anybody got any questions they want to ask? Oh, you've got plenty of questions. Okay, let's start off with Roger Klein.
So,
if you could all questions, please be brief, because I've rather pushed us to the edge of the time. So they've got 6 minutes. So be brief, Roger.
so it's a question about culture, productivity, retention. I work with a number of trusts. They're quite anxious when they start to address culture, but the pressure coming down is more about targets. So could you say a little bit about what the focus is? When a trust is in trouble, culture is generally at the heart of the problem. What kind of support can they expect from NHSE?
Okay, I think it's a very good question. And if you saw the review that I wrote about...
write it down. If you want to take 2 or 3 and I'll...
No, we'll just whip around quickly. We'll remember culture. Begins with a K. culture. Because when I reviewed the workforce plan, the one thing I said that what I thought were disappointing bit of the workforce plan was on page 58, which was the retention piece.
Okay.
I thought that was very weak. I have to say. Anyway, 90 seconds, please, Jim.
I'm so pleased we're working with these trusts. I think you're quite right that when you have issues and problems, when we find issues and problems, actually often the underlying problem is a culture. It is really a cultural problem. And for my private sector experience, that was also the same coming from the world of banking or insurance or asset management. Actually, culture is absolutely critical. And we do understand that the pressure of those top-down targets can actually be an underlying cause of some of the issues we then have in performance if the workforce essentially turns off. So just to give you assurance that we talk about culture, we think about culture a lot, we take good feedback, we do surveys and feedback and try and react to those. In the end, it is, I think that it is top-down signalled and locally delivered. And therefore, I think holding the managers, etc., not to account, but actually to have conversations with them and interventions with them and to see their interventions on a regular basis locally to their workforce is really important, and that we back that. At the moment, the NHSE England and some because of the FTSE Guardians, and I and about 5-6 of our other main board directors are meeting them every single month, and that's to hear from them what's going on in the organisation and to pass that on. The testing sectors on retention. I think there is a lot of good stuff going on in retention, but it's clearly, I'm not going to be Pollyanna-ish. We clearly see significant workforce pressures and we're losing people. Yeah. On retention, the main areas are flexible working, continued professional further development, with changes in pensions, obviously for the more senior staff. And we've got 23 sites at the moment, 23 trusts which are running these programs. Essentially, flexible working, continued development.
The difficulty
and we're seeing a doubling performance, better performance in their sites.
The difficulty with flexible working is the software to enable it. I think you might do well to think about buying a piece of software and licensing to trust that allow people to change their shifts. Anyway, I'm going to I'll start at the back, and if you'd be super quick, because that took far too long.
Sorry, I'll be quick.
It was interesting, but it was far too long.
You're doing page 58.
Well, once I read something, I never forget it, I'm afraid. Got one of those brains.
Hi,
yes, ma'am.
My name is Karen Martin. I actually work exclusively with primary care organisations. I'm interested in how you keep primary care, general practice, community services at the forefront of the mind of the NHSE board, because I think there's a lot of motherhood and apple pie, but in my experience, which is long, it never actually fully translates into that.
Got it. Thank you. Have you got a NED that leads on primary care?
No, we haven't got a current NED. It isn't a single NED who leads on primary care, but just to respond, I expect you'll be sceptical to my response, is actually I don't think it's motherhood at all. And I can absolutely assure you that given that 93% of England's population's health engagement is in primary, the thought that we don't think about that really hard. We've got the primary care contract coming up now, essentially for renewal. Whether we renew or not is probably politically driven. I suspect it won't renew, and we'll make changes to it. And then post an election is probably an easier time then to think about fundamental renewal. Just to reassure you, and certainly from my perspective as the chair of what the board looks at, I would be idiotic not to think harder and harder about primary community. Now, I am surprised coming in that of 158 billion revenue budget, that depending what you include in it, between 9 and 13 billion is the amount of money that's spent on primary, and yet it deals with 93% of the population. But the nature of its engagement, of course, is different. We are very, very focused on primary care. Then again, just to remind you, as you know, 6,600 practices, many of those are small, independent, privately owned businesses. So we don't command them, nor should we. We have to contract with them and incentivize them and then regulate and oversee them. So it's quite a complex area. It's a key priority priority. It is an absolute priority.
It's I think it's a real management juggle. Right, next question. Sorry, sir. We'll come to you in a minute. Yeah, yes, off you go. Final one. Be brief.
Yes, right. I'll try and be brief. I want to make a very important point. I was a GP for 40 years. I worked in the NHS as a frontline doctor for 50 years.
Did you like it?
I loved it until the last 15 years, and I increasingly disliked it, as did all my peers, right? All of them.
Because
we loved it because we were de-skilled. We could no longer practice the art of medicine. It was all about prescribed procedures and protocols and algorithms, and increasingly we were working in, and no one knows anyone but just do as you're told and follow the algorithm culture.
What do you think of the chairman, so when he was commenting earlier, when he was saying we're going to try and lift off the shoulders of primary care, the back office and middle office?
It is an enormous challenge because, for example, if you have destroyed all small general practices, it is very difficult to reintroduce communities within communities. By that I mean the GP who knows their practice nurse, they know their receptionist, they know their assistant, they know the patients, they know the street. Yeah. How on earth do you reintroduce that? And yet, that was the heart, the soul, the spirit.
So there's a 5-letter word.
There's a lot in there.
There's a 5-letter word, which is trust. There's trust. And I think what we need to think about in how we consider primary care, to your very point, is we take, I've used the phrase a couple of times, arthritis and our best, and we only take 15% into medical school, but actually, and other providers, it's not just about doctors. But actually what we do then with our GPs, we train them, and then we put them into GP practice after they come through medical school. And then what do? We give a minutiae of targets and obligations, which actually we pay them for through the contract. So it's a very micro-regulated system. And I think the issue is trust. So I think we should absolutely strip back the number of targets and outcomes the targets we set them, and measure much more on the outcomes for the community that they manage. Now that's a big philosophical shift, and I no doubt will not be accepted by many practitioners, much more expert than I, who will say that QOF is really, really important because it drives behaviours against major pathways. So we've got to get a balance. But my answer to you, and I'm very sorry that your last 15 years were not as much, not fun is the wrong word, but as sort of fulfilling as the previous 25, 35 years, actually it's about that trust and removing micromanagement. Same on CQC. Every GP practice is reviewed every year by CQC. If you have an outstanding practice, why on earth are you going back every single year? There's no change in the personnel. There's lots of things to change.
Why inspect anyway? That's another story. Yes, sir. Can you be quick, please?
Yes, I will. May I ask you a personal question? Do you think an ex-banker and asset manager should be chairman of the NHS England rather than someone who has experience in healthcare?
So it's a very question I asked when I was approached. And I actually had 3 times sounds a bit biblical, but I sort of laughed and said, you must be joking. I've got no health knowledge. And to which the answer was, we have an abundance of health knowledge. That's not the point. We have an abundance of health knowledge. And what we want is people who have run big boards, have done governance, do value for money, KPIs, prioritization, and actually know how to lead and mentor executive teams. Now, that was the answer. And so I then put my hat in the ring after the 3rd time of asking, 6 interview rounds later. Partly to my surprise and my wife's dismay, I ended up there. And you know what? I'm delighted to have done it. It's not enjoyable, but it's hugely engaging and interesting and challenging. And I do think my skills are very relevant, but they're not medical, clearly.
I think that's the role of the non-executive, really. I mean, it's a very important part of the mix. Right, yes, Matt, far away.
Just a quick one, and that is that everything that I'm reading about digital is saying that all of the different hospital trusts across the country have all got different systems. Some of them need 12 passwords to get in to do anything. So before introducing AI and all of the digital programs that are going to make life easier, don't you think that it would be an idea to have everybody on the same system?
So the issue is, it's sort of like a financial system, which I can't, legacy system sitting in banks. It's extremely difficult to do that. It will take a huge amount of time. And one of the reasons for the federated data platform is it doesn't require all of the trusts to rewrite their data to the same machine code. So I think actually what we're doing is by running out an FDP is that actually we can engage with that data even though it's different. Now you're also making a different point, which is frankly the quality of the technology, the systems in many of these places, and we read about faxes and faxes and so on. There is need for investment. The NHS spends 2% of its budget on technology. That's half what Western health systems spends on technology. So we need to spend more on that. But the last point, just as a personal one, is I'm arguing really hard in my board is that actually one of the things that's really important is the NHS number. I referred to it earlier. If you're a hospital, you don't really care about the patient, but you don't really care that it's Richard Meddings having a left knee replacement. You care about the number of left knee replacements you're doing. So actually, you don't automatically need to think about loading to the patient number. Imagine the world in all our secondary and tertiary providers where actually a data aggregation capture point was also your NHS number. The financial services industry will give its eye teeth to a single customer identifier. And what we have in the health service is the NHS number. And if we use that to capture the data and load to the patient, again, think of how different our world might be. And we have that conception.
And
And they do it in
the
Denmark.
technologies.
And they do it in Denmark, smaller country, and they do it in all this.
It's only 7 million people. That's the problem. Yes, sir.
Rahul, I work as a front-end children's doctor, so thank you very much for the whole genome sequencing big input for children. One of the difficulty you're experiencing is cognitive overload. When we ramp up the systems at the front end of the hospital, most of our serious incidents have one factor coming through is that we made the system so fast at the top end for consultants or senior registrars that they do error in their judgment. And if you have any comments, suggestion, review about it, that would be helpful.
Just to say, I haven't heard that before. That doesn't mean I'm denying it, so I need to take that away and think about it. I can say that for my financial services world, that's exactly what's happened in banking. If you look at super fast trading or algorithmic trading, it's beyond human capability to stay up with it. And that means you're asked a different question. You're asked a sort of queuing logic question rather than actually an underlying trading question. So you have to think very differently if you start to get that type of factor at play. But I will honestly think about that, take it away. It's very interesting.
Is anybody else? Have we done? Yes, Angela. Look, quick, answer this question.
Hi, Richard.
Let's get this question right.
The UK used to lead the world for the delivery of real-world evidence studies because of our longitudinal health record. Sadly, it's, again, just like clinical trials, fallen off the cliff. We're very excited about the potential for the federated data platform, but we, having fallen behind because we cannot get access to the data to do the studies, and it's just digital, how are we going to get that back? Because otherwise we're going to end up in the same place as we are with the O'Shaughnessy review.
But I mean, I think you're, Angela, without wishing to be difficult as you're hosting so brilliantly, I think we're going slower than we were, but it's not as almost as we depicted it, it's completely stopped.
I can tell you, we are turning down studies because we cannot deliver, because we cannot get access to the data, and we are jumping through hoops and somersaults with NHS Digital.
Yeah, and so the challenge is partly actually what this gentleman here was talking about, which is actually I think it's not just the process problem of speed and therefore greater demand. The issue, and I slightly talked about it before Roy and I sat down, there's a scaling issue and there's a prioritization issue. And so one of the real challenges isn't to say this is wrong. Of course, we want to do more research and more studies. The question is, how do you give access and capacity to all of it? And then what happens with it? So when I sit at the center, it's rather like when I look at life sciences, which is hugely important, and we're one of the world, if not the world's leader, and we've got brilliant things going on, and medtech, brilliant things going on. But I've got 1,000 voices saying me. And then the question is, okay, well, it's also looking after everybody. What do I do? How do I scale it? And how do I assess it and judge it? So one of the things, again, for me is What's our gating process? What is our prioritization process? How do we sequence this? Do we make choices by pathway? No, because actually, why would you say we're going to do cardiac only or oncology? But how do we? What's my? No, am I okay? So me, the question is, it's a scaling issue, scaling issue versus a very high volume of requests. I do understand your concern. I was in that Office of Life Sciences meeting at 10, which Jeremy hosted, and then every global pharma CEO was in the room. We do get it. The issue for the NHS and for NICE and then IHR, etc., is okay. What do we choose to do?
Maybe we decouple the NHS, NHS England, from that, in the same way that we might decouple you from public health. Maybe there's stuff that it needs to be connected to you, but maybe it should be decoupled. Maybe it should be run by a university or a collection of universities or a separate organisation. I know at the moment everything's being brought back to the centre, but there might be some sense in that.
One of the things actually, which we might talk about, I had a session on research, and I do think that the landscape for research is remarkably cluttered. And the number of different entities and approval entities, you see lots of people, the same people, turning up in another committee, apparently badged or, badged something else. And so you've got lots of research councils, and we've got IHSCMs, and we've got, and all these things are out there. We could do well by decluttering. My best partner as NHS England is actually NICE. So actually Sam Roberts is a really, really important, she and her team are a really important gate. Because actually, if she licensed everything, we will go bust. So there's a real choice about what's affordable amongst all of these good ideas with the partnership.
Yeah, interesting. Listen, I've overrun. I'm really sorry. John gave me one of his Paddington hard stare looks, and so I'm in deep trouble. So I just really want to say thank you, John. Could you just pass me that? Yeah. Well, we have Richard. We have a little tradition going back to the time when we started doing this. How long have we been doing this? 10 years. Where we give our guest a gift. Now this is carefully chosen. It was carefully chosen because it was just over the threshold where people like you and politicians and others who were interested in talking, you have to declare it. That's because I quite like the idea of a lot of lobby people in the NHS having to declare the fact that Roy is bought a bottle of scotch. Now this is a very important bottle of scotch because it's Penderyn, and I'm now going to antagonise almost every audience member we've got north of the border and certainly not south. This is Welsh whiskey. It is the best whiskey in the world, and I risk saying that. And the good thing about it is that one of the few places you could buy it is in Waitrose. So I popped into Waitrose this morning to buy this. Now it isn't £37 anymore. It was actually on offer. So I bought 2 bottles. Well, the other one I was going to bring in for John, but unfortunately I left it at home. So anyway, you've been a great guest. I think the NHS England is in good hands. I hope you agree. Please give a very warm thanks to you. Okay, I think we're going to have a glass of wine. We're all going to be here so you can ask the questions that you've only just thought of asking. Thank you so much for coming. If you're watching, thanks for viewing, and we'll look forward to catching you next time.